If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you.
Okay, welcome to Health Further. Today we have a really good guest, Talha Haseen. He is at Fathom, a new AI company. Well, not new company, but a company new to our audience, maybe. Talha, thanks for doing this. Really appreciate it.
Yeah, absolutely. Thanks for having me.
So before we dive into Fathom, let's talk about your background, because you have a pretty interesting background, a couple turns at McKinsey with some providers mixed in. Maybe tell us about yourself so the audience can get some frame of reference.
Yeah, absolutely. So one, I think I'm proud to say I'm Nashville native. Pretty much went to high school here, grew up here, went to college here, and worked here for a while. It's always, I feel like it's getting even more rare now. But I actually started out as an engineer. I studied chemical engineering and worked as a chemical engineer doing everything except healthcare for maybe like 2 years. So like Greek yogurt production, automotive sector, grocery chains, store chains in like South America, very random things. And I kind of started down this path of healthcare through VUMC, Vanderbilt here in Nashville, by working with like a new department they were starting. Effectively, they were looking for like, someone who wasn't scared of math, wanted to learn a little bit about healthcare and kind of work hard type of thing. Which led to working at the medical center for a while, doing population health related things and helping with a couple of Medicare ACOs and risk stratification for patients. And I kind of discovered the...
When were you?
Go ahead.
When were you at Vanderbilt? Just rough.
About a year and a half, almost 2 years overall. Yeah, around 18.
Like 5 years ago. Yeah, 2018, 2019, pre-COVID.
Yeah.
That time.
Yeah, pre-COVID, exactly, pre-COVID. But that was a phenomenal thing. I actually think, Vic, like I'd love to hear what your opinion might be. I almost like that experience, like framed healthcare to me as like not. I mean, it is like this enormous industry in our economy, but almost framed it as like the intricacies of healthcare come to like I started viewing them as basically almost like a moral question, and the different answers we give to that the questions around healthcare over time, the complex. I literally stopped looking at it like I look at a traditional business completely, and I think that's kind of the case. It forces you to look at it a little differently, given how it works. But long story short, that turned into potentially going to grad school, and then decided to go to McKinsey and Company instead, just because I landed an offer there prior to going. And then I took a little break from McKinsey to help run Envision Healthcare under their CEO and CFO out of Nashville, and then went back to McKinsey after that to finish up the stint, let's call it.
Yeah.
And
I want to not gloss over Envision too quickly. So that was during the No Surprises Act, or right in the before it, or right after it? Because obviously that was a huge change in Envision's business. When were you there, and how did No Surprises affect it when you were there?
Yeah, it was in tow. So I worked under Jim Recton, who is now the Humana CEO. He effectively, as he was coming in after the KKR acquisition and change of the leadership team, it was basically preparing for the No Surprises Act and all the changes that are going to happen in that provider group sector, like practice management space. The No Surprises, I actually ended up spending an enormous amount of time on the NSA. I actually ended up building and designing a lot of the processes at Envision from a technology perspective to do the actual dispute resolution with payers, right? Like you can't do that stuff by hand when you got 10 million patient encounters happening every year. So some of those things, but it changed the way, like, it's actually really, it's almost comical. I quite literally remember being at Envision talking about how hospital medicine contracts the Envision had with hospital systems across the US would shift. They would need to change. And like 2 years later, I remember being at McKinsey on the other side of the table, the health systems basically saying, all these provider groups are asking us for more money. And I'm like, well, yeah, it's because of the NSA.
Yeah.
It's just very, very interesting couple of years in happening in healthcare.
So do you think there was a value shift in the industry through the No Surprises Act, where, I don't know, gross margin or net margin shifted from providers to payers, or maybe I'm interpreting too much into what you're saying?
No, I definitely think so. I think I would characterize it as just leverage being shifted, because the way the NSA is structured, first of all, I think it's a necessary law. Like I don't think there's nothing against that.
Yeah, and there were good intentions behind it, but it had massive ramifications, maybe beyond,
Right.
you know.
Yeah, exactly. Massive implications. I do think, though, the pendulum of leverage shifted away from providers within that space and to payers because of the way the NSA was implemented and the weight specifically that's been given to the QPA and effectively how the QPA is calculated. Like if I get super gritty, if I
the audience, maybe define QPA and then go into
great point. Yeah, so QPA is basically, if I set up the context, right? Let's say, Vic is the doctor and I'm like the insurance company, and Vic and I have not had an agreement. We don't have a contract in place for the insurance is going to pay you this much for this much of your client service or patient service that you're doing per encounter, let's call it, or whatever CPT code. In that situation, the QPA becomes the default right answer because of the NSA. That's a super gross simplification just for context, but that's effectively what the QPA serves as this is the right answer of what you should get paid.
Right, and it really when it gave leverage to payers in the sense that they could opt out of a contract, and then the QPA was going to stand, and so it gave more negotiating power to the payers than they had previously.
Exactly, and if you were a very sophisticated payer leading up to the NSA, because of the QPA was calculated based on the median in-network rate. That is like the approach, right? So if you were a very sophisticated payer, you could lower that prior to the law going live. And it was I mean, it's a great arbitration play.
Right. You lower it, and then if a health system gets frustrated and is no longer in network, then they are getting the QPA, which is by definition, you have pushed it lower.
Yeah. And for frame of reference, it's lower than Medicare rates in certain geographies. So it's not like the QPA is like, oh, it'll probably be around Medicare. It's like, no, it could be lower. It could be like 20% of Medicare.
At Envision, while they were preparing for that, and then you moved to McKinsey consulting with health systems on how to manage this new world of network negotiations.
Yeah, which I mean, the McKinsey work, what I did at McKinsey is basically like just pure health system strategy and growth related work. So it could be, transformation related or growth strategy. So it was always something with health systems, not necessarily provider groups themselves directly. But often this would come up as, where health systems are renegotiating contracts, and the conversation would turn towards, well, how can we just employ all of our physicians? How can you convince them that it's better to work, as an employed physician as opposed to being a contracted one? And can we make that work somehow? And interestingly enough, the aftermath of the NSA, a lot of larger groups such as Envision and a few others that were also located in Nashville or near Nashville, they kind of went belly up, and the groups that they owned ended up being absorbed by those same hospitals, right? It was almost like an opportunity.
Yeah. So the result was many more salary docs.
Yeah.
And a sort of a changing of the negotiating power across the whole industry.
Yeah, exactly. Which a few weeks, not long ago, all the other pressures that are happening towards the payer, unrelated to this, it's kind of building into this momentous thing of like, payers are terrible overall, given, you look at where the leverage might be, and then also what's happening with denials and whatnot. Not that that's necessarily true. It's just a sentiment thing that I definitely think is growing.
Whoever is managing the claims adjudication is always going to be in a position of the bad cop, right? That's their job. Yeah. There. And that's sort of why they are put in place. And this American system we have has checks and balances, a lot like our legal system, where there are two sides that are fighting over what the right network price should be. And in general, that kind of works as long as the two sides have equal or near equal negotiating power. And
exactly.
Depending on the region, sometimes that's true, sometimes not true in the country.
Yeah, exactly.
Okay, so you're at McKinsey, and then you decide to join a healthcare startup, which is quite a change from the trajectory before that. So talk to me about that decision. What did you see in Fathom, or what were you looking for when you jumped over?
Yeah, I think it's definitely, I think if I look at like my traditional career, like decision making, it's definitely it's departing from that. But I think from the spirit of the things that I wanted to do lifelong, like, long term, it's definitely attuned to that. Like I had a couple of in between or concurrent to some of these roles, like entrepreneurial ventures that I worked on with friends, which are like small things. They weren't like huge things, but it was purely with the idea of like, hey, let's do something for ourselves. It'd be fun. And it'd be nice if we make some money too. But well, let's see.
We were talking earlier, you made a couple angel investments too, right?
I did. So what turned out is like I had a couple other friends who were also either in banking or consulting or were software developers, and we were all doing due diligences for PE firms at our current work, like either on the banking side helping with the transaction or through consulting. And we were like, well, could we just do something similar for ourselves? Like we may not have the data, but we can probably make some decent decisions if we make enough of them. And that led to putting a bunch, like around 2019 and prior to COVID, investing in a couple of companies, one of which that IPO'd, which is kind of amazing, and then a few others that are doing fairly well. Some that actually did horrible, like there were some awful decisions.
That's the game, right? You're always going to have some that do well, but you lead with the IPO or the big winners because they're more fun.
Yeah, exactly. So it was good. I think that kind of also gave me the umph of the second time around at McKinsey. I kind of was thinking I'm either going to stay here and just go run for becoming a partner at some point, or I need to go do the thing of doing something on my own and risk the if I don't achieve what I wanted to achieve, I don't, or I keep trying until I do. So
kind of bet on yourself a little bit.
Yeah, which honestly, like it is more, when I think about it and reflect, like it's actually more attuned to like how I make decisions and do things than I used to think it is. So, but Fathom, that specific point, Fathom I actually ran into when I was at Envision. I knew about them, and I knew the co-founder and CEO Andrew, and I kind of just stayed in touch because I was like, my intuition was these seem like really smart people working on a problem that I'm somewhat familiar with, not deeply, but intuitively it made sense to me that there's the way that they were solving the problem. I was like, this seems like the right way to do it. And I just stayed in touch. And then it happened so that they were looking to grow in a way that I was looking to grow, and decided to leave consulting again. And jump ship.
Okay. So, you're not a founder at Fathom, but give us the origin story. How did Fathom grow up? Because it's been, I think they're maybe 8 or 10 years old. They're a little bit, they've been around for a while, but they're really just like coming into a lot of strength right now. So tell us the story of Fathom.
Yeah, absolutely. I'll do my best. So Fathom actually started out. So Fathom today is like an AI company that does medical coding. It started out as a company called TinyRx, and it was focused on pharmaceuticals and like effectively getting patients the right drugs at the right prices and so on. The co-founders, Andrew and Chris, pretty quickly, I think, after exploring the idea of TinyRx and taking to market, realized that this wasn't where they wanted to build a business, or it wasn't going to have the type of impact that they wanted. There's a lot of pharmacy companies as well, so it's very lots of precipitated ideas in that space. And they shifted gears and started looking at where else they could make an impact in healthcare. This is actually within the backdrop of Google releasing the attention is all you need paper, which is around the transformer architecture, which is quite literally why we have ChatGPT and all these other models. And at the early stages, I think they had a hunch of we could use this technology and with enough data, we could truly fully automate medical coding or some other administrative tasks within healthcare. And it started off with, okay, well, who's got the most data? Let's go to billing companies. Let's go to the ones that are aggregating all these encounters and see if we can build something that's meaningful. And since then, it's grown into most of our pipeline now is like, large health systems, payers directly, effectively the consumers of that medical coding output, as opposed to like resellers of that service.
Yeah. So just to recap, make sure I'm following, in 2018, 2019, 2020, when Sam Altman and Elon Musk and others were working on sort of the broader AGI LLMs for society, TinyX shifted to be Fathom and really focused on medical billing and coding as its primary use case for the transformer-based AI models.
Effectively, it focused just on that as a problem area, not to be kind of like, the answer to 10 questions to everybody, but really we can do this one thing and we can do it better than anybody else. And that's what we do. And doing that with medical coding specifically. I will say this, since then, like today, like the stack of models that is used is grown significantly. Like there's the effectively like our model itself that does all the heavy lifting. Then we've started to experiment with, can we use like existing LLMs to help us with the edges? Like, is it easier for it to identify this element once we've gone through? So it's been like an amazing thing over the last year to see how, because it keeps continuously evolving as things get better. There's almost like this benefit of the overarching investment that everybody else keeps doing, like these Sam Altmans of the world.
Yeah.
But
I think one of the things I want to just make sure the audience recognizes, because it's why I wanted to have you on, is that almost all of the existing healthcare AI solutions, except for Fathom, sort of started with a general purpose LLM, and then they've fine-tuned it for the use case in healthcare that they're approaching. And Fathom's quite different than that, where you all started with developing a kind of a deep learning LLM transformer-based architecture around medical billing and coding specifically. And so it would be very good at writing poetry or writing a sales plan, but it's purpose-driven for the use case that you're using it for right now.
Exactly. Yeah. It is one use case of doing the actual medical coding and doing all of the medical coding, not just like one sub-element of what is considered medical code. Like medical coding might have like 10 sub-jobs, right, associated with it. It's Fathom's not like it's doing the whole thing. It's effectively, the goal was quite literally, we want to be a medical coder that just sits in the cloud and can do, hundreds, thousands and thousands of volume of charts and do them more accurately and faster than any human would be able to do.
So, and it started in ambulatory, right, at the clinic level. That's
yeah.
So it's for a primary care doc or a physician group. They have a team of medical coders now, or they outsource it to another country or internally in the US. And so your proposition is, let us replace those people, whether they're inside the practice or outsourced, as still people that are reviewing the charts and then making the codes and submitting the codes. We will take that and fully automate it, and you won't need those people anymore.
Yeah, or you'll need them to do something else instead of do coding itself, right? But exactly that. It's like we will all of the what is like normally considered like production medical coding. Like you might have like 30 people focused on this one production medical coding workflow, and it's like, well, now we only need 2 people to do that work, which is the stuff that Fathom can't do. And then the remaining team can focus on, provider education, CDI related things, all sorts of other stuff.
Fathom has a different model than a lot of AI comes away. It's not the co-pilot sort of, we will ride alongside you and make you better at the job. Instead, it is the AI is going to do all of this work, and it's better than humans at certain aspects of coding.
Exactly. Yeah, it's exactly. It is built for that purpose. Like there is no UI for it, there's no even like you can't log in anywhere. Like it's quite literally like we show you that it works like with doing coding concurrently to your existing coding operation, and then what we do is super transparently audit, like let's say 10,000 encounters, some large scale, so it's not like a back end team somewhere. human coding it. It's like, it's some large amount, and we turn it around in, let's say, like 45, 90 minutes. And we give it back, and we start doing an audit against a client's existing coding.
All the coding for last year, and then your system will do that in 90 minutes or something like that. Very quickly.
Very quickly.
See, like apples to apples. Okay, these are the same patients, same doc, same interaction, same chart, and here's the billing that would have occurred under Fathom.
Yeah. I have I have a working vanity metric, like in one of our like internal, invoice and financial documents, where I basically back into like, if all of our clients had full staffed human medical coders, like how many would they need to do the volume that we were doing? And it is substantially larger than the headcount at Fathom. And we're only like 70 people or 75 people right now.
Yeah. Right. So you'd need 500 people to do all this code.
Right. Yeah. And it scales very quickly. Like there's a very large client that's going live right now, and that's going to be like, 2-3x the number it is now without having to scale the efforts.
Yeah. I mean, that's the beauty of these models, is that as they get better quality and they are accurate and reliable, which is a big threshold that I want to come back to. But once they are, then you can spin up additional servers, additional processes, but it's adding another software instance. It's not a significant cost.
Yeah, exactly. Like I actually think there's not a monetary cost, but there's definitely like a headache cost. Like if a health system or a provider group or who have you is changing from coding vendor A to coding vendor B, and they're both human coders, it's kind of like it's very easy for them to think about that. It's very new and different to think about, we need to integrate with the EMR, this company needs to build a model, we need to do this verification, quality checks and whatnot. I think it's a little bit of that adds some friction, but I've seen over the last like 7-8 months that friction go down pretty substantially. Like people are getting very used to the idea of, okay, we want to do it differently, significantly differently.
Yeah, and I think it seems like it's a much stronger return on investment kind of economic value proposition to the health system to be able to do a full replacement as long as it is reliable and accurate. So talk about the process of Fathom. We were talking earlier, it's almost an exponential curve of how hard it is to you can get the first 30% of coding done pretty easily. It's not complicated. Anyone could really kind of quickly do it. But as you get to 50%, 70%, it gets exponentially harder. Where is that process? How does that work? And where is that Fathom now?
Yeah, so Fathom's most I guess like the things that really matter are like, what's the automation, which is like effectively like recall rate of the model, like how much can you automate, and what's your accuracy, like coding accuracy with what you are automating. Vast majority of specialties that Fathom works for clients and actively is paid for, they're like 90% automation. We expect every specialty to be above 90% automation in the future. I think the lowest ones we have are around 70, and those are like surgeries, oncology related things, lower volume stuff that is bespoke. But like emergency medicine, primary care, radiology, we have a client that's at 99% automation, a health system client with radiology. And the accuracy is we contractually guarantee 95% accuracy, which is like the industry standard.
Yeah. Humans really can't do any better. Yeah.
No, I mean, they can, but you would need them to spend a lot more time with each encounter. Like humans can't do 10,000 encounters at 95% accuracy in 2 days. You need a lot, or you need bigger teams. But the thing you mentioned about like automation rate, about the first 30% or 40% being easy. One thing that I've seen, even from Fathom's competitors and also from the co-founders talk about this in depth, is getting to like the 50% automation with 95% accuracy, like a useful product, right? Like things that people would bill. Getting to 50% was not that hard. Like it was hard, but it wasn't like, it was achievable. Going from 50, 60 range to like 90% or 90% plus, vastly more difficult than just getting the first 50%. And I think, and this is honestly one of the reasons I joined Fathom, is like the hypothesis of Fathom is automation rates and accuracy will drive the winner, like in this market. I can't imagine any health system CFO being like, oh, I can automate 50%. That's good enough. When they have an option, somebody else that says, well, we can do 90%. You can have.
Yeah. And given the sort of proprietary and dedicated focus of the model, I assume there probably are great sort of benefits to scale. Like as you add on new health systems, additional specialties, you get more and more inputs, and it gets stronger over time.
Absolutely. Yeah. I think so Apollo MD is a large medical group that all of their emergency medicine as a specialty like Fathom handles. So that gives us an enormous scope of emergency medicine coding for us, right? So as we add net new emergency medicine, like every time we add a new emergency medicine client now, they benefit from the fact that we've already seen so much emergency medicine in the US.
Yeah, it's kind of the classic network advantage that Fathom is taking advantage of, where every time you sign up another health system, it makes the base stronger and it helps you sign up that next one and next one, and you have a further moat, basically.
Yeah, exactly. It kind of just builds this. I think we have somewhere around almost $250 million, little shy of that right now, I think, but almost there, of historical patient encounters that we've trained the model on.
Okay, and so let's talk about what you're doing at Fathom, because I think you are working more on the inpatient side of things, which is very different, as most of the audience will know. It's not ICD-10, but DRG codes, which is different. So where is the product maturity in there? What's the roadmap look like? How is that process going?
Yeah. Well, I'm doing it. One of the things I actually I literally remember sitting down, talking about this. Like one of the reasons I joined Fathom was like, I want to be at a high growth company and get the experience of scaling something, which means inherently doing a bunch of different things. So depending on the day and the hour, I've got a different hat on, but the inpatient piece is something I'm helping drive, which is, so the only piece of medical coding that Fathom can't currently do today is inpatient facility coding. So every other specialty under the sun, whether it's risk adjustment repairs, whether it's primary care, emergency medicine, facility side, or the professional side, two sides of the coin for that one, and any of the others we can pretty much do. The inpatient facility is the only thing that we currently can't do, and that's a way more complex than primary care coding. All hospital revenue depends on that. So what I've been doing for the last 6 months or so is building a consortium of design partners. So effectively about 5 or 6 health systems is what we imagine will end up being, that are partnering with Fathom to build the inpatient product. And that's something we decided as an organization that we need to do. Like we can't build that product without a health system partner that's going to be helping us design it, because the workflows of inpatient coding, like I was actually on a bunch of calls this morning discovering the workflow of one of the systems that we're going to be partnering with. And I was like, oh, wow, this is very complex. This is so complex that I imagine a lot of people that work at this system don't fully understand how this is actually done. The amount of teams, the amount of people, the amount of technology that's used to do all of that. It's a lot of stuff going on.
And is it because it touches several different parts of an organization, and then so the billing has to like pull information from different areas and be more integrated than an ambulatory clinic setting? It's more like we had this patient encounter and now let's bill for it. Is that close to right or no?
Yeah, I think that's a part of it. That's a big part of it. A big part of it is the fact that inpatient care is very acute. You have an enormous amount of documentation. So that's one. Like documentation is being generated daily, multiple times a day. Tests, nurse notes, physician notes, rounding that happens on each patient's. And then in addition to that, there's, from an administrative perspective, inpatient coding is also a massive liability pitfall. It is very easy to go into a hospital coding or billing department and effectively put yourself at risk because your policies or the way that you're coding does not look appropriate to an authoritative body. And that's never what you want, right? Like large hospitals are going to become targets to things like that. So I think because of that, because you have to avoid risks like that, the operation is really complex. Like there is the revenue side of like, hey, are we coding this accurately? Like from a clinical perspective. And then there's the side of, are we coding this accurately from a DRG perspective relative to like revenue? Are we showing that we did all the work that we did? And those two things, systems, I've noticed a lot of systems like address that differently. Like some systems have a combined operation where everything falls under the chief revenue officer. And other systems are like, this part of coding sits under quality and this part of coding sits under revenue. So it's organized a bit differently.
Yeah, and there's some systems I think have a belief that leads to better care because they're sort of separating the quality of care from the drive for more revenue. Yeah,
exactly. And I think it's I mean, I see the intention of why the separation needs to exist, right? I think Mayo has got it that way. It's completely separated out. Like it's a quality department. The other one's what does the final coding is like a revenue leader. But taking that into account, right? Like if Fathom's going to put out an inpatient product that can do the inpatient facility coding, and the workflow is way more complicated than what it would be like on primary care, where you just code the chart, you send it back, and you send it out the door. A lot more complex, a lot more revenue, opportunity or risk associated as well in making sure things are correct and accurate.
Yeah.
The other fun thing actually, go ahead, you're going to say something.
No, give me your fun thing. I want to hear that.
Yeah. One crazy thing I see about inpatient is like the inpatient market is kind of in a chokehold from a coding perspective by 3M and Optum. Like there's no real players that are automating or tackling the inpatient problem using modern tools or using any real AI. And I know every company's got AI in their name now as well, but like today, the inpatient coding operation is basically throw a bunch of bodies at the problem and give them tools that are made by 3M and Optum and audit them until it's accurate.
Yeah,
that's quite literally how every operation works. There's no like reimagining, like, hey, maybe the simple cases should be fully automated and the stuff that's really complex should go through a really heavy duty review as opposed to just this one team that's going to manage everything.
Yeah.
And the other pattern that I'm seeing is the availability of certified coders. Basically, people, and my mom used to be a coder actually when I was younger.
It's a hard job.
It's a hard job, and they don't exist.
Low paying job, and people don't want to do it.
Yeah. Well, there's not many of them. There's just not like that many. Because a lot of folks retired. A lot of coders retired during the COVID time, and a lot of them, most of them aren't coming back. And either are, a lot of new folks that are entering the job market, they're not necessarily looking at medical coding like they used to, let's say in the early 2000s or so.
Yeah, and 3M certainly has some innovation in the platform, but Optum is a little bit the fox guarding the hen house a little bit. Like I'm not sure that they are the best partner long term for health systems. They do great work, and I'm sure they keep everything separated. But it's just a hard parent organization there.
Yeah, exactly. And I just can't imagine Optum or 3M coming out with a solution that is like highly performant and very AI forward. I mean, I've seen some stuff from Solventum or 3M, but nothing that's kind of blown the market away or anything.
Yeah. So I want to change gears for a minute. We just had last week, and JP Morgan is this week, of course. It's a busy January. But I want Elon Musk was in an interview at CES, and he said that, of course, he's Elon Musk, right? So he is trying to get things for effect, I think, a lot of times. But he said, in his view, all cognitive tasks will be able to be done by AI in 2 to 3 years, and which is just floored me. And so what I wanted to get your thoughts on is let's leave all cognitive tasks to the side. And also let's forget about the clinical, like actually making clinical decisions about the patient's care in the moment.
Yep.
I know there's some AI involved in that, but Fathom is in the administrative billing side, and a lot of the successful early tools are not in clinical; they're in administrative.
Yeah.
How far do you think we are away from where, let's pick a number, 90%, 95% of those administrative services will be able to be done by an AI tool, like largely automated, fully automated?
Yeah, that's a great question. Do you follow Qventus by any chance? The company Qventus?
Yeah, I do.
They just raised like did you see that the other day or a couple of days ago?
I didn't see their raise.
They raised a Series D, about 105 million, basically specifically for this, like agentic solutions towards all administrative tasks that could be automated in a hospital. And I'm sure they're not doing everything for a hospital, but but I think it speaks to at least the same thing that you're getting at. So if I start small, medical coding, I think this is just an execution problem now. There's no like technical or scientific risk left within that administrative task. The other tasks, like the faxes that hospitals still have to send, some like all those things that really shouldn't have to do, or there are other administrative things that nurses have to do that could be automated. I genuinely think that stuff is going to get automated. Maybe it's 5 to 6 years, a little longer. I haven't dug into like what are the great tools, but I know there's an enormous amount of tools, and that Qventus investment being one example. I just can't imagine it taking longer than 5 to 10 years, given all the existing technology that we have. And I mean, I've started building like little agentic systems to do small things for me, like update some Excel files based on some regular reports that are updated.
Yeah, it's incredible. So I think what's interesting is that there's a lot of fear, and Elon talked about, what are the humans going to do? If all cognitive tasks are done by machines, what are we all going to do?
Yeah.
And that is pretty scary outside of healthcare. But as you mentioned, in healthcare, the job of coding, there's not a lot of people that are 18 years old that like their dream in life is to go into that. And simultaneously, if we take administrative burden off nurses or doctors or any of our people, that's a great thing. I mean, they're overworked, they have a lot of stress. Taking away administrative duties and allowing them to focus on the patients, focus on sort of care at the bedside, I think could be wonderful. Is there a downside to that, or do you think that could play out in 5 years, 8 years?
I think it could certainly play out. I'm sure that I think there's trade-offs to it. I mean, I think what you're kind of getting at is like displacement of jobs, basically, right? Like things that currently exist. So here's a interesting. I'll answer that with like a real life example. I think. So I gave the example of my mom being a medical coder when I was a kid, right? I imagine like I asked myself this, like, what if medical coding was not available as a job? What would she have done? Like she was really just like, I'm going to try to take care of, do what I can for my family and whatnot.
It makes the money.
Yeah, a part of me wonders if she would have been forced into it to do something that's entrepreneurial at some point. Because at some point, if there's not a structured, simple path, such as, it could be medical coding, it could be even all sorts of careers or things that you could do. Folks, what's the other option left? I think the other option is like, well, I'm going to do something that I think I'm decent at, and I'm just going to go and see if I can earn money from it.
Yeah.
And I think a part of that displacement will actually increase the amount of folks that are at least trying to do something like that.
Yeah, I think that's right. The reason I'm optimistic in healthcare as opposed to call centers or fintech or law or some other industry is that I think in-person empathetic care where we're trying to help the patient live slightly healthier life, stay on their medication, maybe side effects. There's a lot of things that healthcare staff could really be empowered to do that would be, I think, more fulfilling or as fulfilling as coding. and could maybe make the job, maybe it pays the same, but they're able to engage with the patient more and really sort of affect it.
Yeah, I think the scribe AI companies like the Abridges or DAX, Nuance, they're already seeing great outcomes from that, where physicians are spending so much fewer hours on documentation and actually able to be like, oh, I could probably see another patient today because I don't need to chart as much.
And when they're in the room, they're not having to take as many notes and do their coding while they're talking to the person, which has, bad customer service issues.
Yeah, exactly. Good quality impact there too. Yeah, I say that in a funny way. Like my girlfriend's a family med doc, and she spends a lot of time doing charting like after hours, like really a lot of time, and just because of the patient load. And she's like, well, this AI better work.
Waiting for it. Yeah.
Yeah, just quite literally waiting for it. Yeah.
Yeah. Okay, so I wanted to talk through that to ask the next question, which is, if billing and coding becomes fully automated with Fathom and others, the other side of the claims processing, the payer side, is also using AI and really ramping up. They might even be ahead of the health system side. And so is there going to be a kind of a balance of power, or even like an arms race to see who can be either billing with more evidence and justification and knowing how the payers are going to adjudicate things so that you preempt that and submit claims that are going to be paid, versus the payers, questioning things more and more often? It feels like there's kind of an arms race. What are your thoughts about that?
Yeah, I definitely think there's a bit of an AI arms race there, simply because of, the arms race has already existed. It just was powered by humans, right, on both sides of the table there, and now it's just going to be kind of supercharged for a bit before some balancing occurs. I think the payers have always been ahead from a technology perspective because their industry has forced them to be. Like they're, the amount of data that they have to go through, and they just simply have to rely on technology more.
And they're more centralized in general. Where
yeah, exactly. So I think that they will absolutely be ahead of the providers. I just can't imagine a world where they wouldn't be. Funny enough, I think, and I mentioned this maybe the other week, I know of a couple of companies, one in particular that's doing quite well, that's still in like stealth mode. They've got I think 8 or 9 payer clients now, but all like pilots. But effectively what they're doing is helping payers benchmark their own policy, helping payer A, benchmark its policies around medical necessity guidelines, which often can result in denials, against other payers. And not all payers are sophisticated or have the same level of maturity with those guidelines. And this is something that I just immediately see like, well, okay, if payer A starts changing their medical guidelines based on payer B's existing guidelines, which would have required, 50 people to work nonstop to digest those, and now it's just, 2 LLMs can create a summary of that in seconds. There's a faster iteration, faster pace of change that's going to occur. And if providers on the other end don't catch up, there's just going to be an incompletable gap between the two organizations in terms of pace of change and whatnot. I definitely think, I actually get asked this all the time, even from the inpatient work that's happening. Most health system chief revenue officers or even CFOs will actually, during those partnership conversations, say, where's basically the denials piece of this? Are you going to do that after coding? Is that later? Where's it on your roadmap? We're not going to immediately solve that problem. We have so much to solve with just medical coding, but there are definitely other organizations that are working on it. The one that I mentioned that's doing it for payers is actually also doing it for providers, at least for the medical necessity side. But I think I actually feel like what are your take? You think the arms race is actually here? I feel like we're probably like 6-7 months out before we actually start seeing things in scale.
Yeah, I think it's next January is my guess of when it really starts to be. The way I think about an arms race is it's detrimental to not have an AI tool helping the administrative side. And right now, I think there's a lot of, you're in the space, but my interpretation is there's a lot of taking what humans have done for years and doing that faster, cheaper, more reliably, maybe with slightly more depth. But I think there's going to be a time when Fathom and others can start to learn from the feedback that your health systems are getting from payers, and whether you move into denials or you just sort of feed that back into the algorithm development, to start now coding it slightly differently to optimize the revenue as opposed to optimize the amount billed.
Right.
What health systems really care about is how much cash they're getting. And then simultaneously, your friend and others will be doing the same thing on the payer side and trying to, that's where the arms race comes in. They try to catch up.
Yep. Yeah, exactly. I think it's I feel like there's money to be made in the arms race.
Yeah.
As in all arms race.
There's money to be made between picks and shovels at a gold rush. Probably better calling you selling picks and shovels and serving drinks in front of the gold mines than being an arms dealer. So
Yeah, exactly. Yeah, exactly. It's going to be I think you're right. I haven't seen, at least from I've seen the same level of like panic around, or not panic, but concern around like denials. And because I haven't seen a change, my sense is, oh, the payers haven't released, the AIs.
yeah,
There'd be much more panic and concern in people's voices if there was like some deep learning model that was denying them.
Definitely. Okay, and then given this pace of change is really fast, how do you keep up with things yourself? How do you stay abreast of what's going on? Are there podcasts or maybe a newsletter you read or something that you could feel around?
Yeah, your podcast.
Oh, good.
That's definitely
if you're listening to this, they already have that. So yeah.
Well, that's to reaffirm the decision, I guess. But other than that, there's a couple of great newsletters. One's called like TLDR. It's all tech overall, not just healthcare. I like that one because you can see a lot of things that are tools that are being built that you can very easily see. Okay, this would be applicable in healthcare because of XYZ reason. The other thing that I like to do is keep seeing how the effectively our government's reacting to AI as well, because in changes in legislation, there's a fairly substantial piece of AI that NVIDIA just commented on the other day that was released by the Biden administration, and there's some interesting things there to keep in mind as well. Funny enough, I think the easiest way has been to do it is like no one's really like at the bleeding edge of it, unless maybe you're like a Sam Altman that's happening to talk to like NVIDIA's CEO about the new chips that are coming out. So you're probably not missing that much. The only other
we're late adopters in healthcare, so I think what happens is we will watch how consumer tech works and maybe how financial services or the Mag 7 big software guys are doing it. And then once it gets sort of some of the bugs out and is really much more reliable, then healthcare will adopt it. And so monitoring that and sort of seeing things out on the horizon that maybe are still kind of a little bit of a science project, but watching it evolve, I think, is what my audience needs to do.
Yeah, exactly. I pay attention to, or try to at least, is like funding rounds, like the Cuventus series, just because I almost treat that as like, okay, here's money that's going to subsidize a pilot at a bunch of systems that will try something new. Right. So it's worth at least looking at that. The other interesting thing, I feel like this is probably a little bit less relevant of staying in touch, but also how folks have been talking about public markets going into the end of 2024 and into 25. Effectively, like, I think there's like a big Goldman Sachs report about it being like, depressed returns and whatnot. I think about it there too, because that type of news can't be encouraging, the Cuventuses of the world to say, oh, we should IPO in 25. Mm-hmm. It's just not setting up like the win. I mean, maybe it still is, I don't know for sure, but I try to keep a lens there as well. Like, what are the broad strokes here?
Are there other countries that you think we should pay attention to? Like, I'm trying to watch the Middle East because I think Saudi Arabia and UAE are doing some interesting stuff. China, of course, is always interesting, but they're hard to get any information out of.
Yeah. But you can get information, you just don't know if it'll be. Fair enough. I think there's an enormous amount of investment happening in Saudi and the UAE. I actually have a really good friend of mine who went to undergrad at Vandy with me, who's from Saudi and is provided me with like some really interesting views about, you know, how he thinks about the kingdom and the direction they're going. But they're spending an enormous amount of money to effectively, you know, shift their economy, and AI has been a pretty significant driver of that, is like recently. But from like a purely AI perspective, I feel like everybody's like a standard deviation behind the US at the moment. Like the chips, the talent, the ability to push it. So there's that. I do think about like what will happen from a going into 25 and well, there a change in administration and whatnot. What's going to happen that might happen in Europe, might happen in the Middle East, that may impact us as an economy in general. You know, second or third order impacts, but I think from an AI development perspective, unless we put a structural barrier in place to not allow companies to invest or move as fast as they're wanting to, it feels like paying attention to the domestic pieces is more valuable.
Yeah, I think that's right. I mean, I think you're right. We have the hard technology, the chips. We have the talent, kind of the software engineering, brains, and then the financial markets too are much stronger, much more risk tolerant here, where you can have massive amounts of startup investment happen, which, you know, a lot is going to fail, but it's still that like creative destruction, just like the American economy is incredible. I sort of keep going with that.
Yeah, and it's like I'm much more naturally like an optimist. Like I'm willing to try something, like even personally, like I actually think I scare my parents, or I used to, with that habit. But it's great to me because it's, as long as you don't take those things personally as like as an economy, it's like that's what we need to do. Like to keep
always
going.
Testing and learning and evolving and iterating as an economy.
Yeah, exactly. Like I there's that big GC acquisition of Sumo. Sumo Healthcare. So basically like a, you know, private equity or VC, basically in an allocator buying a hospital. Still, it's crazy.
I'm excited to see what they do with it. It's going to be fun to watch.
Yeah, me too. I feel like that might be one of the first places where they try to just be like, every administrative task needs to be done by AI, or like if it can be done by AI, it needs to be done by AI. Right. So I'm interested to see if they go that extreme and when they do. But
I think you and I can learn a lot from that. Whether it all works out or not, General Catalyst will be brilliant or not so brilliant, but we'll get to watch and learn from the side.
Yeah. I think they're doing okay.
Yeah.
I think they'll be all right. Got a couple of good investments, especially with the AI stuff, right?
Yeah. So, they're great. Oh, thanks for doing this. Before we go, give people a handoff. Where can they find you? Maybe a website or the Fathom website or LinkedIn. Where do you hang out? Where should they find
you? Absolutely. I think fathomhealth.com would probably be the easiest place and direct place to find me. LinkedIn, obviously, you know, Talha Haseen, you can find me there. Other than that, I'm at Frothy Monkey in Nashville a lot. So
nice. Which one? Like 12 South or downtown?
Yeah, I like going to the 12 South one. I'll just go there. It just gets so busy though, so you got to pick and choose when I want to go.
Maybe like twice a week. So, but
oh, do you?
Yeah.
Okay. No way. Is there? Yeah, that's great. Is your office? Do you have an office downtown as well?
I have an office downtown, right near TPAC, and there's a Frothy Monkey.
Okay. Yeah. Oh, that's perfect. Yeah, that's a great location too. Yeah.
Excellent. Well, I'll put this information, and then I'll catch up with you and get the TLDR link so people can have the link to your website, to Fathom website, and your LinkedIn and this newsletter in the show notes, so in case they miss those, go by. But thanks for doing this. Really appreciate it.
Yeah, absolutely. This is great. Thanks for having me.